The esophagus moves partially digested food from the mouth to the stomach. If food cannot reach the stomach, the patient cannot meet the human need for nutrition. Problems of the esophagus that can interfere with digestion and nutrition are caused by inflammation, structural defects, or obstruction or cancer. Gastroesophageal reflux disease, aka GERD, is the most common upper GI disorder in the United States. It is most common in middle-aged or older adults, but anyone can have it. At-risk people are smokers, drinkers, Thanksgiving feasters, patients with NG tubes because the tube holds the sphincter open, a tight belt and girdle wearers because it increases intra-abdominal pressure, pregnancy, and sometimes bending over when you have ascites or a large abdomen, or overweight or obese people. GERD occurs as a result of reflux of the GI contents into the esophagus. Symptoms are produced because the delicate esophageal tissue is exposed to the harsh gastric or duodenal contents, resulting in inflammation. This can be mild or severe. So let's review. This is usually prevented by the upper esophageal sphincter and lower esophageal sphincter. It's usually prevented by the presence of two high-pressured areas that remain contracted at rest. The most common cause is the lower esophageal sphincter relaxation. The most common at night is because of decreased peristalsis and lack of gravity. The danger of reflux is that over time, that inflammation triggers increased blood flow to the area and erosion or ulceration can occur. There is a risk for hemorrhage. The body's smart. Chronic inflammation tells the body to change the cell types, but that's never a good idea. Barrett's epithelium occurs after chronic inflammation triggers the body to substitute columnar epithelium for the usual squamous cells because the columnar is more resistant to the acid. While this seems like a good idea, it's actually precancerous and pre-malignant. So prolonged GERD can lead to cancer. Furthermore, all the inflammation can lead to scarring, which means esophageal strictures. This places patients at risk for aspiration pneumonia. Complications include adult onset asthma, laryngitis, dental decay, and cardiac disease. Not quite sure why yet. Smoking and drinking alcohol weaken the muscle tone of the lower esophageal sphincter. Esophageal stricture or narrowing of the esophagus may occur related to fibrosis and scarring. So to recap, complications of GERD lead to hemorrhage, aspiration pneumonia, adult onset asthma, laryngitis, dental decay, and it can also be associated with cardiac disease. And the causes of increased intra-abdominal pressure can be a result of pregnancy, wearing tight belts, bending over, ascites, or obesity. Okay, so let's discuss a little bit about collaborative care. We have the physical assessment findings such as heartburn, also known as dyspepsia, regurgitation, ecrectation, also known as belching, flatulence, bloating, lung crackles if they're aspirated, coughing, hoarseness, wheezing at night, bronchitis. Chronic GERD causes dysphagia, that's difficulty swallowing. Remember, think about the strictures. And then adenophagia, it's painful swallowing, asthma, and atypical chest pain. Diagnostic assessments include a 24-hour esophageal pH monitoring. This is a catheter that is placed through the nose into the distal esophagus. Patients keep a diary of when and what they eat and what they are doing. Then there's method 2. It's an EGD. Patients are sedated and they go down the throat to look with a camera and a scope. Tissue samples can be taken. Then method 3 is the esophageal manometry. It's not common, and this is a water-filled catheter that is inserted and slowly withdrawn to measure the lower esophagus sphincter pressure. Nursing interventions include treatment that is centered around relieving symptoms, treat esophagitis, and prevent complications. Your role as a nurse educator is very important here. This is a chronic condition that will need management. They want to eliminate foods that decrease the lower esophagus sphincter pressure, like chocolate, alcohol, fried and fatty foods, caffeine, and carbonated drinks. They want to restrict their spicy and acidic foods until healing has occurred. They want to avoid big meals. They want to eat small meals. They want to eat slowly and chew well to help digestion and prevent belching. There may need to be weight reduction if it's indicated. You want to teach them to keep their head of bed elevated at night. Teach them to sleep on the right side. Ask them about what medications they're on, because some will actually decrease the lower esophagus sphincter pressure. You want to teach them to avoid alcohol and smoking. There's also a Stretta procedure. This is a radiofrequency energy that passes via the endoscope using needles that are placed near the gastroesophageal junction. This decreases vagus nerve activity and pain. Then there is the endoluminal gastroplication using the barred endoscint suturing system. Sutures are placed near the sphincter, allowing tightening of the lower esophagus sphincter. Laparoscopic Nissen fundoplication is a minimally invasive surgery. It has become the gold standard for surgical management. Okay, I want to talk a little bit about drug therapy. It involves three categories: antacids, histamine blockers, and proton pump inhibitors. You want to note prokinetic drugs. These drugs have one or more of these functions. They inhibit gastric acid secretion, accelerate gastric emptying, and or protect the gastric mucosa. Antacids are effective for occasional episodes of heartburn. They act to elevate the pH level of the gastric contents, deactivating pepsin. It also increases the lower esophageal sphincter pressure, so it's not given for long-term use. Antacids include Maalox, Mylanta. They need to take 1 hour before meals or 2 to 3 hours after meals. Then we have Gaviscon, which can be taken with food. Histamine receptor antagonist blockers are such as Pepcid, Zantac, and Axid decreased acid. OTC, over-the-counter in a low doses. Prescription is needed for the higher doses. There are histamine blockers such as Pepcid, Zantac, and Axid. Then we have the proton pump inhibitors such as Prilosec, Prevacid. Prevacid is over-the-counter. There's also Acifex, Protonix, and Nexium. The main treatment are for more severe of GERD. You want to act on the proton pump of the gastric parietal cell. You want to reduce gastric acid secretion. Long-term use may cause community-acquired pneumonia and GI infections. Hip fracture risk goes up with these drugs even after a few years of treatment. Proton pump inhibitors are such as Nexium, Protonix, and Acifex. These shut down the proton pump of the parietal cells. These can interfere with the absorption of calcium and protein digestion. Okay, so let's now talk about hiatal hernia. It involves the protrusion of the stomach through the esophageal hiatus of the diaphragm into the chest. There are two types. There is the sliding and the rolling. Sliding is the most common type. Sliding hernias slide upward through the esophageal hiatus into the chest, and this is usually due to a weakening of the diaphragm. Reflux is the major concern with this. In rolling hernias, you get part of the stomach that rolls upward through into the chest cavity beside the esophagus. The risk of volvulus, or twisting, causes an obstruction and strangulation, which are high. Iron deficiency anemia is common. It is a result from anatomical defects. This image depicts a normal stomach, a sliding hiatal hernia, and a rolling hiatal hernia. Okay, so now we're going to discuss a little bit of the collaborative care. Nursing assessment will include heartburn, regurgitation, pain, dysphagia, and belching. You want to note the location, onset, duration, and quality of the pain. What makes it better? What makes it worse? Auscultate the lungs. Symptoms usually worsen at night or after a big meal. For rolling hernias, they may feel suffocated or breathless, they may have chest pain, or they may have a feeling of very full. Diagnostics include barium swallow with fluoroscopy and EGD. Interventions will include drugs, antacids, histamine blockers, and nutrition guidelines. Surgical could be a laparoscopic Nissen fundoplication. Post-op care will include risk for bleeding or risk for infection. They may have an NG tube. Oral intake begins after peristalsis returns. They will have an incentive spirometry. You may also think about whether they'll have chest tubes. They may have gas bloat syndrome. They may have aerophagia. A barium swallow study with fluoroscopy is the most specific diagnostic test. Sliding hernias are treated more medically, and rolling are treated more by surgery due to risk factors. Non-surgical management are to decrease obesity, sleep with the head of the bed up at 6 inches, for them to remain upright after eating, for them to avoid straining, for them to refrain from wearing clothing that is tight and constrictive. Surgical interventions, they may need fiber post-op so they don't bust any stitches doing their business. They need to avoid being around people who are sick. They have to eat smaller meals. They have to make the dietary changes. They have to avoid drinking with straws. They need to avoid gum. And they need to avoid alcoholic and carbonated beverages. Gas bloat syndrome, they're unable to voluntarily belch, and it's usually temporary. And then for aerophagia, that's air swallowing, you want to teach patients to eat slowly and chew well. Let's talk about esophageal tumors. They're usually malignant, they grow rapidly, and by the time of diagnosis, it usually has spread. 2 risk factors are tobacco and heavy alcohol intake. Long-term untreated GERD can lead to esophageal adenocarcinomas. It's also been noted to have high levels of nitroamines, which are found in pickled and fermented foods, and nitrate. They have a lack of fruits and a lack of vegetables. Common clinical manifestations are dysphagia, stricture, autonophagia, halitosis, chronic hiccups, and hoarseness. You can identify it through a barium swallow study with fluoroscopy. Definitive diagnosis is by the esophageal ultrasound with a fine needle aspiration to examine the tumor. The major concern for a patient with esophageal cancer is weight loss secondary to dysphagia. Gastrostomy or jejunostomy may be created, and you want to monitor for aspiration. Non-surgical treatment options include nutrition therapy, swallowing therapy, chemotherapy, radiation therapy, chemoradiation, and targeted therapies, photodynamic therapy, esophageal dilation, and endoscopic therapies. Usually conventional surgery is needed because of the lack of symptoms until late into the disease. Procedures can include an esophagectomy or esophagogastrostomy. You want to prep by having them stop smoking, boost nutritional balance, dental evaluation, and dental hygiene. Post-op, there will be respiratory care, which is your highest priority. There could be a chest tube drainage, fluid volume changes, and wound management. You want to monitor healing and infection risk. Monitor for the NG tube. Don't move it. Nutritional management will include to teach them to eat 6 to 8 small meals with fluids between meals and not with their meals. And then to have them watch for diarrhea, which is related to vagotomy syndrome. Okay, now let's talk about esophageal diverticula. These are sacs that are resulting from the herniation of esophageal mucosa and submucosa into the surrounding tissue. It can develop anywhere along the esophagus. Patient reports dysphagia, regurgitation, nocturnal cough, and halitosis. There is a risk for perforation. It's diagnosed by an EGD. They want to eat semi-solid food in small, frequent feedings. These work the best. Now let's talk about esophageal trauma. These can cause by blunt injuries, chemical burns, surgery, or endoscopy, or the stress of continuous severe vomiting. If excessive force is exerted, it may rupture and caustic acid is secreted to the mediastinal cavity, and there is a high mortality. You want to assess for airway patency, breathing, chest pain, dysphagia, vomiting, and bleeding as the priority for this patient care. Antibiotics will be ordered and steroids to decrease inflammation. This concludes the lesson of care of patients with GI alterations part 2. If you have any questions related to the lesson content, contact the instructor.